So modern ideas about healthcare delivery make a mockery of our planning. Canadian primary healthcare HHR planning, PHC, primary healthcare HHR, health human resource planning is tough for very good reasons. We need to better understand our policy environment, and that's I'm going to bore you tomorrow if you come to hear my speech too about this, that I really think that we need to have a much better diagnostic of what's going wrong in the policy environment, and we have to be much better versed in what the solutions might be. So I think many people in Canada, of course, have seen this data recently from the Commonwealth Fund showing that Canada wins gold in terms of the difficulty of Canadians getting after-hours care without going to the emergency room. And we also win gold in using emergency rooms. And these are obviously related. Aside, I don't know what's wrong with Norway here, but Canada is the worst aside from Norway in terms of waiting to see a specialist. And here's a wonderful example of the kind of stupid processes that we have that make people think we don't have enough human resources when we may well have too many. This was a study done last year showing that of patients who saw a spine surgeon, you can wait a year or more in Ontario to see a spine surgeon, most of whom are neurosurgeons, some communities they're orthopedic surgeons. And then you'd think, well, okay, well, once you get to see a spine surgeon, I mean, a spine surgeon isn't going to help you if you have a non-surgical problem. A rehab medicine specialist will help you more. A physiotherapist will help you more. An OT will help you more. Probably a social worker would help you a whole lot more than seeing a spine surgeon. So if you're waiting in line to see a spine surgeon, you are in the wrong line. So it turns out that now, I'm sure that I checked this out with a surgeon a couple of days ago, and he agreed that fewer than 100% of patients who are referred to a surgeon should go on to surgery, but it shouldn't be 10%. It should be at least 50%. Really, it should probably be 70 or 80%. So that and is the solution to that problem creating more surgeons? I don't think so. So, and we all, I think people in this room would know that certainly in southern Canada, for 90–95% of Canadians who live either in Edmonton or within 100 kilometers of the Canadian border, because Edmonton's the only city I think that's more than 100 km from the US border rather, that we could have elective surgery within 2 months. We could certainly get elective specialty input that we need to start our case within a week. And we should all be able to see either our family doctor or somebody on our family doctor's team within 24 hours. 24/7 care, within 24-hour access to a regular source of primary health care, within 7-day access to needed specialty input to get your case started. And we could get a lot better access if we use non-professionals in the mix as well. So we all know this, and using frameworks like the expanded chronic care model designed by the folks in Vancouver, out of Wagner's model out of Seattle. This is the Ontario version. This really, when you think of the way that most Canadians get their primary health care and their follow-up for diabetes and hypertension, every 3 months going to see a doctor who only does about 10% or 20% of what should be done in follow-up. A diagram of frameworks like this really highlight how missing our healthcare system is, our primary healthcare system is. So this all means that you seriously need to re-engineer the system. In fact, probably 80–90% of services that are delivered in primary healthcare are the wrong person or the wrong service. Mm-hmm. Yeah. Health human resource deployment would look a lot different if we incorporated these new ideas. More use of other professionals and non-professionals, such as home care aides and lay community health workers. And physician workdays would be dramatically different. Much more time spent supporting and coaching other providers, and more face time with complex patients. So Canadian HHR planning is tough, and there's some really good reasons why it's tough. We're a federation, not a unified state, and we are the world's most decentralized federation. There's no other federation I know of in the world where the federal government spends less than 50% of the public's expenditures. In Canada, it's down to about 40%, and after Mr. Harper is through, it's God knows where it's going to be. And healthcare is a provincial responsibility, and the federal government, as we all know and as we've heard this morning, is withdrawn from healthcare. So at the provincial level, reform continues to be agonizingly slow, as we continue to talk about at this meeting, and we seem to be getting inured to an inefficient delivery models based upon outdated processes, which are mainly based on continued medical dominance in health policy decisions. So the political notion of medical dominance may have changed, but the institutions and the decision-making processes are very resistant to change. And I'm happy to go into some more details about the evidence of this. But it's still right there. The doctors are still in charge, and as a study I did last year revealed, dig deep into Ontario's primary healthcare planning, and it's right there in the manuals and everything. The OMA is still very much in charge. So in summary, modern ideas about healthcare delivery really make a mockery of the way we have tended to plan health human resources. Our deployment of health human resources would look very different if we listen to the evidence. But that this is tough stuff for good reasons. And then looking to how we get out of this, and as people were starting to talk about today, where do we go from here? You will get, I'm afraid, a lot more of that tomorrow from me. But just as an introduction to that, I think, as John Dewey would say, if the problem is not enough democracy, the solution is more democracy. And I think we need a lot more democracy and openness to our health human resource planning debates. And I wouldn't be here at my age still trying to convince some of you of my ideas if I didn't believe what Tommy Douglas said, that we can make a better world. Thank you very much. Thank you. I think first of all, to make the point, of course, that Canada is one of the more urbanized countries in the world, and notwithstanding our gigantic geography, we are huddled together in cities, and so the reality of Canada is very different than a lot of the myths that we think of. But even in remote areas, again, when one looks at the examples of simply using advanced access. That when we see examples where physicians routinely can add 200 to 500 patients to their practice and see them pretty much within 24 hours, that there's no shortage of anything in this country, although in some rural and remote areas there just aren't people. But even there, we're not nearly using telehealth the way we should. And why aren't we? Because it's I think in most provinces I know of, it's still optional up to the physician. So in one province I was doing some work recently, you want to bring your patient down and that costs $1,500, $2,000 or whatever, that's fine. You don't want to, that's fine too. We'll set you up on telehealth. So, that we could have unbelievably better access. And of course, we've had the model for how to better enhance specialty care in this country, right in looking at DOT, right at Hamilton, right? With Nick Cates and his shared care mental health program that many of you are familiar with. And that's been applied in Winnipeg probably as well or better as in Hamilton. But still, we haven't fully integrated psychiatrists in most of Canada into primary health care teams the way they have been in those two cities. And we've done virtually nothing for any other specialist, notwithstanding some champions in specialty medicine like Mary Bell, a rheumatologist at Sunnybrook, who would love to get rheumatologists integrated in primary healthcare practices. So that we're hardly short of anything, and if we didn't have this open-ended invitation to physicians still to practice wherever they want, see whichever patients they want, work whatever days they want. It's amazing that you've got as many physicians in what many of us consider to be less desirable places in the country to live, right? And again, as been mentioned, we've known for many, many years what are the factors that will enhance people going to remote and rural areas. Mainly, of course, it's people who grew up there. But you have to start usually in junior high to make sure that the students are interested enough in science and everything to get into university to begin with. So some of you may know of Damien Contandriopoulos' paper a couple of years ago, and I really like the way that he put, we shouldn't be talking about what we should be doing anymore. We should be talking about how we implement it. And so that the meetings I want to have, and I've been telling, when Jeff Turnbull and the CMA were running around the country a couple of years ago, I said, Jeff, I love you. He's a saint. Everybody who knows Jeff, he's a complete saint. But I said, you're asking stupid questions. You're running around the country asking, what's the role of the consumer? What's the role of this? What's the role of that? The questions you should be asking is, if we had all specialists in this country working the way the psychiatrists are in Nick Cates' program in Hamilton, no one would ever wait longer, max, than 7 days to get the needed specialty input to start off their case. So the question we should be asking is, how can we implement that model for all specialty care in Canada within 2 years? And that's the question we should ask. And then when doctors say, well, I don't get paid to work like that, then we say, yeah, well, that's a real problem. We got to deal with that, but we're paying you lots of money, so we'll make sure that you don't lose any income. And then the real issue. I don't want to work that way, because my idea of being a specialist is that I sit on a throne and patients and their family doctors crawl on their bellies for 4 miles over glass to get to me. And if they're not doing that, I just don't feel I'm a real doctor. Okay, well, that's a problem, because you are not allowed to, you can think like that, but you can't act like that anymore. So, and that gets us into where I think the solutions have to lie, which is having the right people together in the right places with the right processes so we can get to the real issues.